right. Looks like we have enough people to get going here. Thanks everyone for attending. Our session today titled Working Together to Advance Children's Health Policy. Today's session is being hosted by Healthcare Ready and the Pediatric Pandemic Network. If you're not familiar with us, Healthcare Ready is a nonprofit dedicated to building resilient communities that are prepared for, can respond to, and recover from disasters and disease outbreaks. We leverage unique relationships with government, nonprofit, and medical supply chains to build and enhance the resiliency of communities before, during, and after disasters, with, of course, a focus on equity, which is a very salient topic for today, speaking of pediatrics, which is a population of concern when it comes to equity. Without further ado, I'm going to hand it over for an introduction from our host, our co-host, Kevin McCulley from the Pediatric Pandemic Network, their Chief Operating Officer. Over to you, Kevin.
Thanks, Tom, and hello, everyone. Many of you, I'm certain we've crossed paths before. For others, let me give you a little bit of background about the PPN and about the criticality of this project. For those that aren't aware, the PPN is a national network that's come together to close gaps in readiness, resiliency, response, and research for children as a result of global health threats, disasters, and everyday emergencies. We're actually funded through HRSA, Maternal and Child Health Bureau, and we're a partner network to a group that many of you may have some familiarity with, and that is the EMS for Children's program. From our foundation, really based on a collective impact philosophy, the members of the PPN include 13 major children's hospitals across the nation, serving as our key hub site entities, a variety of other children's hospitals and individual subject matter experts who bring specific expertise to various elements of our work. And we work in partnership with a number of national organizations and associations, such as our partners today from Children's Hospital Association and Healthcare Ready. We also work closely with our partners on the HHS ASPR side, Pediatric Disaster Centers of Excellence. And collectively, we are working to bring pediatric expertise to the emergency management world and to bring emergency management into the pediatric healthcare infrastructure. Our network is composed of a variety of cores and topic area domains working to elevate the role of children's hospitals by impacting readiness and preparedness within their catchment areas, while simultaneously working to improve the care that's provided for children every day in children's hospitals and in our community and other out-of-hospital partners. And for those that may not be aware, the PPN is partnered with Healthcare Ready on this critical project around enhancing preparedness and resilience within pediatric healthcare. And in particular, Healthcare Ready has taken on a role of leading a supply chain task force as a part of the PPN's operations, using its expertise to really think about the unique supply and the supply challenges that are faced by pediatric healthcare systems. This partnership is really focused on implementing effective strategies to ensure that pediatric populations receive uninterrupted care during disasters. A key component of this strategy is really ensuring, as I mentioned, that pediatric readiness and preparedness is elevated and represented across all levels, from advocacy groups to government agencies, from frontline EDs to community health centers, even into the C-suites within our institutions. And even though today is really the final virtual session that'll be jointly hosted, the work really doesn't stop here. This work will continue, as we've seen, even in recent months, even specific supply chain shortages, whether it's IV or other fluids, whether it's blood culture collection bottles, or whether it's things like infant formula, can have a devastating impact on the continuity of care for pediatric populations. And so through this session, we actively invite you to collaborate, bring your experiences, share your insights, and really allow us to continue to move this work forward. I think I will pass it back to our healthcare ready partners to get us going on the session. Thank you all.
Thanks very much, Kevin. And I think this is a particularly timely uh, session to hold now, as policy is going to become very important, and we're heading into a critical period of the year for disease seasonality around pediatric care. So very excited to have you all here. And again, thank you, Kevin, for those opening remarks. Very quickly, we'll go through the agenda. As Kevin indicated, we're very pleased to have guest speakers from the Children's Hospital Association, Aimee Ossman and Natalie Torentinos, sorry. And then Healthcare Ready my colleagues will give a brief presentation on our organization and our work in this space as well. Both will have a Q&A period, so please do jot down any questions and we'll get to them at the end. If you don't have any questions, we will call on people to give us their thoughts. And then if we can advance into the learning objectives, they should be on your screen now. And just in brief, we're going to understand the federal policy priorities from our experts at the Children's Hospital Association and identify opportunities and challenges for advancing those policies. There's a lot of opportunities for collaboration. A lot of folks on this call, a lot of familiar faces on this call too, as Kevin indicated. So there's a lot of opportunity for us to join together and pursue these policy priorities and ways that we can engage at all levels, both at the federal level, in the various agencies at the federal level, but also in other agencies, state and local as well. So we've got a big agenda to go through. But first, we're going to have a icebreaker. But I know we're all in the pediatric space, so we won't make it, going around the room and saying something unique about us. But I'm really interested to hear from folks on this call. What is one federal policy issue or initiative that has made the greatest impact on pediatric healthcare supply chain so far? And there has been a number of them, especially in the past couple of years since COVID-19. So if you could pop that right in the chat, we'll give everybody a few minutes. I'm watching Pat Frost type furiously. We're all going to come in at once. Angie, maybe you want to give your thoughts. Oh, good. We got a couple. I knew they were all going to come in at once. Angie, you're off the hook. But I'm coming back to you maybe. Michael says FEMA's public assistance policy guide, which does not include pediatric feeding support in Pennsylvania Emergency Protective Measures Category B. Kevin, thank you. Establishment of the National Advisory Committee on Children's and Disasters. Absolutely. Just seeing if anyone else is coming in. That National Advisory Committee on Children and Disasters, Kevin, do you want to talk about the influence that has on ASPR's policies and priorities and a little bit about how it's structured maybe?
Sure. Well, many of the members that participate on the committee are also subject matter experts within the PPN. And so it's really established to provide expert advice and consultation to HHS on the needs of on the medical and public health needs of children in disasters. And so even more broadly, even though ASPR might be the hosting agency, the impacts and the recommendations that come out of this group are certainly things that we take as we think about our work strategically through the PPN and with regard to our partnerships over.
Outstanding. And I think it also just demonstrates a prioritization or leaning into identifying the specific needs for children in disasters. There's not many of these national advisory committees. There's only a handful, and so this is a good sign. Michael, just going back to your public assistance policy guide, not having pediatric feeding support, appreciate the yet, very optimistic. I think it does indicate a lot of the general national directives and guides and guidelines coming out are not necessarily catering to the special considerations for pediatric care. And I think that that'll be a topic of today's conversation, certainly future conversations.
Tom, thank you. I'm sorry to interrupt. Thank you for that, because what's interesting is that it's actually contrary to CDC and American Academy of Pediatrics guidance. So we've been working on this for over a year, and there's a lot to it. I'll put another link in that progress is being made.
Please do. Thank you. Pat Frost talked about the DPA, the Defense Production Act. This act allows quote unquote wartime powers for the federal government to play a more active role in supply chain, especially mitigating any particular shortages, was activated during COVID-19, of course, and more recently in the IV solution shortage. Thanks, Pat Frost, for that. Ronald talks about lower payment for healthcare services for children drives closure of pediatric facilities. The financial aspect of maintaining a good response healthcare capability within this country. Absolutely. That is a major concern in creating pediatric care deserts in some parts of the country. Pat Frost says expansion of Medicaid and the CHIP Act. Absolutely. Michael added more about ESF 6, where pediatric feeding belongs. Yeah, absolutely. I couldn't agree with you more on that, actually, Michael. It's something that I've had a lot of conversations on personally. DSC SA, the, oh gosh, I'm going to mess up it, pronouncing what this acronym is. But this is the new regulation around drug tracking. And it creates a bit of a barrier to entry, I would say, but also allows for greater tracking and surveillance of any particular. Yeah, thank you. The Drug Supply Chain Security Act, thank you. It also allows for additional tracking if there are any reactions to drugs or the need to, thanks, Kevin, the need to recall any particular drug. So I think this is good. This is a great start. Appreciate everybody who shouted out and trying to read these as fast as I can and bearing with me as I comment on them. But there's a lot there, and there's a lot more that needs to happen. And I think that that's the nature of our conversation today. So without further ado, I want to hand it over to our guest speakers who are going to dig into this a little bit more. Aimee and Natalie. Aimee is the Vice President of Policy at the Children's Hospital Association, representing over 220 children's hospitals dedicated to improving child health through innovation in care, education, and research. She leads the association's policy efforts, which support children's hospitals' advocacy on Medicaid, CHIP, and other children's health policy issues. This includes leading efforts to influence development and implementation of major health policies that impact children's hospitals and their patients. Prior to joining Children's Hospital Association, Aimee held a variety of health policy positions inside and outside of government. Welcome, Aimee. And Natalie Torentinos serves as policy manager for CHA, where she helps develop regulatory comments and advanced policy positions with the administration and Congress, and previously worked at the American College of Cardiology as a lobbyist, covering the appropriations committees. She studied history and journalism at the University of Delaware and political management at the George Washington University here in Washington, D.C. Thank you both for being here. Over to you.
Thank you, Tom, and thank you all for having us today. We obviously partner a lot with Healthcare Ready, the PPN, Asper's Centers of Excellence, and many other partners that have already been mentioned, AAP, other hospital groups, different advocacy groups. So we can't do what we do alone. So we are really happy to partner with all of you on these critical issues for children. You can go to the next slide. So what we wanted to cover today is just a little bit of an overview of CHA. I know many of you are familiar with us in our work, and we're going to focus on our policy and advocacy work, but obviously we do broader things at the Children's Hospital Association. We'll talk about our advocacy priorities and the status of them as we think about moving forward, closing out this year, and then into 2025. We'll talk about our broad awareness work and some of the visibility work that we've done to kind of raise the visibility of the importance of children's hospitals when we think about care for kids, when we think about response to disasters and any crisis, just making sure that's front and center as federal policymakers are thinking about policies that they want to move forward. And then we'll definitely leave a lot of time for discussion and questions. We want to hear what's top of mind for you all. You can go to the next slide. So we are champions for children's health at the Children's Hospital Association. We're the only pediatric focused hospital association. Obviously, we bring together and collaborate very closely with our over 220 children's hospitals across the country, which are our members. And we work with them to decide what are going to be our policy priorities and what are we going to be focusing on in our conversations collectively with federal policymakers. You can go to the next slide. So this seems very basic, but for people who don't do policy and advocacy in their everyday life, we just wanted to kind of level set. And some of the themes we've already heard. So when we are talking to federal policymakers, the first thing we're trying to do is raise children as a consideration, as a focus. You know, people think, oh, I'm sure that's top of mind for them already. That's not always the case. Obviously, they have a lot of things going on, a lot of issues they're trying to move forward. And sometimes they're not considering what would be the impact on kids. What do we need to consider for kids? So when we're having conversations with federal policymakers, that's our first goal, is to raise up children and the impact on children. We obviously want to also highlight the critical role that children's hospitals play for children and the need to make sure we're providing appropriate support for children's hospitals so they can do all the amazing things that they do for their patients, but also children and families in their communities. And as you all talk about a lot, what they're doing collectively together on disaster preparedness or to address some of the other issues that come up, shortages, et cetera, like the Baxter shortage. So that's what we focus on when we're having conversations with federal policymakers at a high level. You can go to the next slide. So obviously we have different things that are going to impact our work as we think about the election results. It's like I was saying to Natalie, it's like the shortest bullet that needs the most description there. So we obviously had an election last year. We know, some of the results, some are still coming in terms of control of the House. But obviously the Senate has flipped and it will be controlled by Republicans. We have a new President-elect Trump, who's going to be taking office and creating his administration and bringing folks in to lead. And so we're taking a look at all of that. I think one of the great things about CHA is we are a strongly bipartisan organization. And that's the way we do our work. Many of the major pieces of legislation that we have been able to get enacted have been strongly bipartisan and have occurred under Republican administrations and Democratic administrations. So right now we're kind of looking at the landscape, working with we have a cadre of advisors who help us in terms of providing strategy advice, but also help us with developing relationships. One thing is for certain, there's going to be a lot of new folks, in Congress, a lot of new staff in Congress, and a lot of new folks in the administration. There will be new political appointees. There may be civil servants who decide, this is a time when they're going to be making some changes too. So for sure, we're going to have to do a lot of education in terms of pediatrics and our priority issues, and make sure that we're highlighting those with our elected officials. And as we've seen, I've been at CHA for 23 years, been through a lot of different administrations, a lot of different changes in Congress. There's always opportunities and challenges when we look forward. And so we are working to assess those and how we can be best positioned and prepared for some of those opportunities and challenges as we go forward. So in terms of finishing out this year, Congress returned today from their recess, and number one thing they have to do before the end of the year is fund the government. There's a short-term funding mechanism that's in place until December 20th. And so there'll have to be some decisions made then. How long are they going to extend government funding? There is some talk right now, it may be to March. There could be other options that are on the table. It's a little unclear what that time frame will look like. But obviously that's important for all of the programs that you all are engaged in that get funding, and thinking about what that funding is going to be and for how long. So that's an important aspect for us. We also, expect, as they're talking about funding the government, there's going to be an active lame duck session. Now, what the lame duck session looks like and how much actually moves forward, that's still, we still need to assess where we're going to be with that. But we're looking at some opportunities that we have, some policies that we are trying to advance right now to see if we can get those over the finish line this year. If not, then of course we'll have to reintroduce them next year and continue the fight on those. And we'll talk a little bit about that. And we've already talked about how bipartisanship will continue to be really important, though, it may be a Republican sweep. These aren't by large numbers. And so it still won't be necessarily easy to get things passed through Congress with the small margins. So that's something else to consider as you think about the policy and political environment. You can go to the next slide. So we're going to talk today about some of our broader policy priorities, which I know are kind of foundational for all of the work that you all do. And then Natalie will get into a little bit more detail on some of the issues that you're most interested in. So for the Children's Hospital Association, we have these three buckets, which are our main policy priorities. The pediatric workforce. We know there's workforce challenges across the board in our country. There's healthcare workforce challenges, and there definitely is pediatric healthcare workforce challenges. And so we're looking at opportunities to get additional funding that's targeted to pediatrics as we work with federal policymakers. We are also still focused on children's mental health. That is and continues to be a crisis for our hospitals. Our hospitals continue to see many children coming into their emergency rooms, boarding in their emergency rooms because there's nowhere else to go to get children's mental health support and services. And so we're continuing to work in that area, and we'll talk in more detail about some specific things we're working to push forward. Medicaid, of course, is always a major priority for us. Children's hospitals, on average, over 50% of the patients in their hospitals are covered by Medicaid. So changes in Medicaid can make a big difference for children's hospitals and the patients that they care for, and a lot of the work that they do more broadly. So we work to protect Medicaid and then also look for ways in which we can improve the program for kids and for children's hospitals. We're also always looking, and this kind of cuts across all of these priorities. Our hospitals have to be financially sustainable to be able to do their missions and do all the great work that you all are engaged in. And so we're always making sure that there's appropriate support and making the case for that with federal policymakers. You can go to the next slide. You can go to the next slide. So we're going to start with pediatric workforce, and just at a high level, some of the things that we're working on and looking at right now. So obviously a major program for children's hospitals is the Children's Hospital Graduate Medical Education Program. It provides funding for the training of over 50% of pediatricians and pediatric specialists. This is the training that happens for the most part at our freestanding children's hospitals who don't qualify for Medicare GME. And so this is really important, and we're the only advocates for this. If we aren't advocating for this, no one's advocating for this. And so we're continuing to push for robust funding. Right now, the program still only supports about half of what Medicare does for the training of a physician, and that's a problem. And so we're trying to raise that up and get more robust funding at the same time that we need to reauthorize the program. So on this, we have to work for reauthorization and also work for funding. Right now, we're very focused on the funding piece. There have been some challenges with reauthorization, some riders that people want to add that we don't support. And so we're really focused on the funding for the program right now. So obviously that's focused on physicians, but there's a lot of workforce issues more broadly, the non-physician workforce that you all know. And so we're looking at ways that we can support and get more support at the federal level for training and retention, some more support for the existing workforce. And of course, we're always looking for ways in which we can increase support through Medicaid. That's obviously a major payer for kids and to support pediatric providers. And so looking for different opportunities there to be able to move some support forward and some dedicated support, because whenever it's general support, it never seems to make it to pediatrics and to kids. And so we want to make sure of that as we go forward. You can go to the next slide. So in order to get some better data to support our advocacy efforts, we did do an assessment and gathered information from children's hospitals to see where were the major shortages that you're experiencing when you look at physician specialties, but also the non-physician workforce. And on this slide, you can kind of see what our hospitals reported, some of the highest shortage areas, the biggest pain points. And with the QR code, if you want to get some more information, we have some information on our website. You can access that through that QR code. So this data should help us as we continue to make the case for additional support for the pediatric workforce and to be able to speak about examples that are specific to kids when we're talking to federal policymakers. You can go to the next slide. So moving into children's mental health, there are a couple of legislative vehicles that we are currently supporting. The first one, Helping Kids Cope Act, is a bipartisan bill that we have supported over a couple of Congresses, and it would create new grant programs and provide additional support in the areas of community-based support, workforce, and infrastructure for pediatric behavioral health. And this one has been hard to advance because they are new grant programs and it would be additional money. And that's very hard to get bipartisan support for in Congress right now, at least in the current environment. And so that bill has been introduced in the House, and it does have a growing list of co-sponsors, but it hasn't advanced past that. And I'm not sure it's going to be in play in terms of the lame duck session that we talked about, just because it's a larger bill and has additional money attached to it. We're also working on the Early Minds Act, which would allow more funding to go to prevention under the mental health block grant, which is a current funding stream to support mental health services. And we're hoping maybe this one, because it is more targeted, may have an opportunity to move forward. And it would provide some needed funding that's targeted to early prevention and early intervention services. We will need to continue to work with Congress as we assess our new members of Congress and the administration on what are our opportunities as we go forward and as we work with children's hospitals. What are the most important issues in the area of children's mental health that we should be focusing on as we go into the new Congress and the new administration. You can go to the next slide. So Medicaid. Medicaid is obviously a lot of the work that we do, and there's many different issues that we're working on related to Medicaid. So as I said at the beginning, we are working to safeguard and protect the program, and particularly the funding for the program, so that there aren't any negative impact on children's hospitals and the care that they provide to kids in their hospitals, but also in their communities. So we are working to delay the disproportionate share hospital payments that would go into effect at the end of this year if they're not delayed further. We've pushed for them to be delayed to the end of this year, and are pushing and advocating for that delay to continue. Disproportionate share hospital payments often do go to children's hospitals, and so that would be a negative change if that went into effect. We also were able to get some positive changes through a Medicaid managed care rule that was finalized this year that allows more supplemental payments under Medicaid managed care, which are state-directed payments that many children's hospitals receive from their states, which are really important to their ability to continue their missions and provide the care that they do. So we were happy to see that. Obviously, supplemental payments and Medicaid funding is something we need to keep our eye on as we go forward, and talk about the importance of the Medicaid program to kids and to children's hospitals with our new federal policymakers. So in terms of opportunities to improve the program, I'm going to focus on a couple of them. Another one that's not listed here that may be relevant is we are also working on hospital at home. So we have a number of children's hospitals that want to develop a hospital at home program, but they want to do it, obviously they want to do it for children under Medicaid, and the one vehicle to do it is actually a Medicare program, which allows Medicare hospitals to do hospital at home. It unfortunately does not allow IPPS exempt hospitals, like mostly freestanding children's hospitals, to participate in that program. So when state Medicaid programs are looking to put their programs in place, they're relying on eligibility for that Medicare program, which unfortunately many children's hospitals can't participate in. So we're working on how we can get a pathway for those hospitals to be able to have a hospital at home program in place. Obviously, it would be really important in times when we have capacity issues. Someone mentioned a lot of pediatric beds are going away. And if there was an issue where we're trying to manage capacity, having a hospital at home program is one way in which we could better manage that. So trying to make sure that children's hospitals have the opportunity to participate in a program like that. So we're working with CMS and champions and folks in the Hill to hopefully get a pathway there for children's hospitals. You can move to the next slide. So one of the opportunities, one of the good news items is Accelerating Kids Access to Care Act. This is a bill that would streamline out-of-state provider enrollment under Medicaid for when a child is going to come from another state to your hospital or to your state to get care. They have to enroll in that other state's Medicaid program, the hospital, but also all the providers that are going to care for that child. And for each state that a child comes to the hospital from, you have to do different paperwork and meet different requirements. And for some hospitals who see children from, sometimes all 50 states, that's a lot of administrative burden. So this bill would allow providers to enroll in one streamlined system, and then it would be good for all 50 states. Now, this does not affect the state Medicaid program's authority to decide when a child needs to go across state lines to get care. It's just once that has been approved, streamlining the out-of-state provider enrollment aspect. So this bill is very strongly bipartisan. It passed the House in September. We have a pretty manageable CBO, Congressional Budget Office score. It was reduced pretty significantly after a lot of conversations, and we have a growing list of co-sponsors. So this one is pretty well positioned depending on what happens at the end of the year and how big or how many things Congress wants to move forward before they leave at the end of the year. You can go to the next slide. Another opportunity for us was the guidance that CMS put together on the early periodic screening, diagnostic, and treatment benefit under Medicaid. That's a lot, but it's basically the children's benefit under Medicaid that's really tailored to kids' unique needs and ensures that if something's medically necessary for that child, Medicaid needs to cover that. So that's different than the coverage requirements and benefits for adults. And so we have been hearing from our hospitals that there's gaps in EPSDT. So though it should be ensuring all these medically necessary services, there's areas that children are not able to access the care that they need. We heard a lot of concerns about children's mental health, about accessing care out of state. And so we did work with other advocacy groups and pediatric provider groups like the AAP and weighed in with CMS. We had worked to get the Bipartisan Safer Communities Act enacted and including a provision saying that CMS had to do guidance and oversight on EPSDT. So now CMS is doing that oversight, and we've been trying to inform that as they were looking at different things and giving them very specific examples of where we thought that clarification or reiteration or really making it clear what should be required and what shouldn't be, or what needs to be required in states, and then some best practices. So for states to learn from each other in terms of things that they could do that could really move this forward so that we're really realizing the promise of EPSDT for kids. And so in September, they released a very long guidance letter. It was 57 pages. And so it was a lot in there. I think, some of what we had asked is reflected in there. Is it as strongly as we would have written it? No. But a lot of our issues they did consider and did include. The one thing is, how are they going to do oversight moving forward? Now that there's a guidance letter, what's the follow-up? How are they going to work with states to really be able to move some of these things forward and not be a letter that sits on a shelf? And so we'll be working with CMS as we go forward. I think if nothing else, this guidance letter is an important tool for you all at the state level when you see gaps and you see things in this letter that says that's not what should be happening, to be able to work with your state and go to them and say, this is a requirement in this guidance, or here's the best practice. Could we consider doing that here in our state? So I think it will be a tool at the state level and hopefully helps you all as you're working on these issues. You can go to the next slide. With that, I'm going to turn it over to Natalie for the next couple slides.
Thanks, Amy, and it's good to be with everyone today. I'm going to go over some of CHA's pharmacy policy and advocacy priorities that we've been working on this year, the last few years. The first of which is educating and addressing drug shortages impacting children. And, what we often share in our comment letters and other educational materials with policymakers is that drug and supply shortages are particularly challenging in pediatric healthcare, given the specific requirements and considerations for children. Pediatric and drug products can go into shortage much more quickly than adult products, and it can take longer for manufacturers to respond and bring adequate product back to market. And we always know that drugs and supplies intended for children are unique, since there are fewer manufacturers of pediatric supplies, which means it's easier to disrupt the supply chain. So in order to address these challenges, we advocate for manufacturer and distributor transparency throughout the supply chain, including the location of production, as well as a timeline for the product availability. We also recommend adjusting the FDA shortages list to provide a timely and accurate accounting of pediatric populations and pediatric drug formulations, including the potential for regional shortages, and also reducing the risk of pediatric drug and supply shortages by encouraging proactive mitigation plans and or competition in production of pediatric products that are often sole sourced or under-resourced. And just to give an idea of what congressional action has looked like recently, there was a proposed piece of legislation by the House Energy and Commerce Committee that would exclude certain generic sterile injectables from the 340B program. CHA had encouraged Congress to preserve access to generic drugs in the 340B program and to work with manufacturers on the establishment of appropriate reimbursement for pediatric generic drugs. And the Senate this year proposed a bill introducing a voluntary incentive payment program for certain generics. In CHA, in our comments, we urge that children's hospitals be eligible to participate in a generics program to ensure that pediatric patients have the same level of access to necessary medications. And then another, I think, a great example of our advocacy in this area is the issue of the IV fluid shortage as a result of the impacts of Hurricane Helene on the North Carolina Baxter facility, and the fact that, we worked with Baxter and HHS to help prioritize pediatric needs and identify solutions for our hospitals. And then another part of this drug shortage work, CHA is engaged as a member of the End Drug Shortages Alliance, which is made up of health systems, supply chain, and industry and other stakeholders that work to solve pharmaceutical supply chain challenges. And CHA holds leadership roles, including currently chairing the board, being chair-elect of the policy committee, and being past chair of the Pediatrics and Special Populations Committee within this alliance. And a number of our children's hospitals are also members. And then I also wanted to note that in August, CHA staff and many of our hospitals' pharmacy leaders joined representatives of the FDA and HHS at the White House to discuss ways to address pediatric cancer drug shortages. And just a few weeks ago, the White House had announced a new private sector pilot program to maintain access to pre-selected critical pediatric cancer medications to begin later this year. And participants will develop standards focused on identifying shortage risks, promoting transparent inventory awareness, and maintaining that consistent drug distribution to children fighting cancer. And so again, just another example of how we're trying to implement some of our key drug shortage priorities that I listed earlier. So moving to the second bullet, which is ensuring equitable access to high-cost therapies and specialty drugs. Just at a high level, pediatric high-cost therapies are innovative and life-saving or life-altering treatments for children with chronic, rare, or complex conditions. However, they are extremely expensive, with many that cost well over $1 million. So these high-cost therapies are crucial to many pediatric patients as they are highly effective when administered earlier in life. And with the disparities in specialty drug reimbursement, it is crucial that policies create equitable access and affordability for these treatments. So to ensure better access, CHA has started a high-cost therapies member work group. So all children's hospitals can speak with a common voice to support patients, providers, and facilities in accessing high-cost therapies in a safe manner. The group is comprised of more than 20 children's hospitals with senior leaders from pharmacy, government relations, finance, or medical expertise. And then within that, we've established a federal policy subgroup made up of 10 government relations professionals, and then utilizing some hospital experts as needed. So the group's goal is to support equitable access across states to high-cost drugs, particularly for children on Medicaid. And the group also met with the CMS Innovation Center to discuss their access model for high-cost therapies and the pediatric perspective. This group has also helped us craft educational documents on high-cost therapies and pediatrics that we can share externally with policymakers. And we are also compiling a list of existing policies being discussed at the federal level and using hospital input to inform our work. And then in September, CHA hosted a panel on equitable access to cures for sickle cell disease during the Congressional Black Caucus annual legislative conference, where our chief medical officer and experts from several of our hospitals participated in a discussion on how new cell and gene therapies that hold potential as cures for sickle cell disease and the challenges of accessing these treatments, especially for children on Medicaid. So the third bullet here is our advocacy work in protecting and improving 340B. The 340B program enables covered entities such as children's hospitals to stretch federal resources in reaching more eligible patients and providing more comprehensive services. And manufacturers participating in Medicaid agree to provide outpatient drugs to covered entities at significantly reduced prices. And this program is especially vital for children's hospitals to serve children regardless of insurance status, and the support provided by the program enables them to help more children, improve access to care, provide more comprehensive services, and many times those are the only source of services in the community. And children's hospitals use 340B savings to help offset low Medicaid reimbursement, subsidize the cost of providing services such as behavioral health, vaccine clinics, hemophilia treatment, and affordable prescription medications. And then opportunities for CHA's 340B advocacy include having the chance to highlight the impact of 340B on hospitals and educate why the program is important, as well as learning from state level actions in hospital efforts to protect access to 340B. But we have been seeing increased scrutiny on 340B in Congress. We've seen a number of bills introduced that include transparency and reporting requirements, eligibility limitations, and restrictions on the use of contract pharmacies. And CHA submitted a response earlier this year to a piece of draft 340B legislation that would address contract pharmacy restrictions, patient definition, transparency, as well as several other issues. And then we've also started a 340B work group consisting of about 20 children's hospitals to gather their feedback on ways we can improve and protect 340B and educate lawmakers on the value of the program. So moving on to the last component here of our pharmacy policy, ensuring that pricing does not disproportionately disadvantage children. This is, in some cases, manufacturers set higher prices for a pediatric indication of a drug based on patient age. So just to give an example, a higher price is charged for a pediatric indication of Kymriah. This is a cellular therapy for leukemia and lymphoma, which would add additional financial barriers for children who need this critical treatment. So again, this is another important component of our advocacy work. Next slide. So moving on to pandemic and emergency preparedness, over the last few years, children's hospitals, as you all know, have experienced an unprecedented level of pediatric patient visits, driven by an increase in childhood respiratory illnesses like RSV, influenza, and of course, COVID. And then we have the ongoing, children's mental health crisis. And these challenges have demonstrated how critical it is for the nation's pandemic preparedness system to account for the differences between the way the physical and mental health care delivery and support systems can support children compared to adults. To help policymakers prioritize pediatric needs, last year CHA published a report called Children's Healthcare Needs in a Pandemic, Disaster, or Public Health Emergency, a National Blueprint for Pediatric Specific Readiness. And this blueprint urges policymakers to address challenges in key areas, such as strengthening the national pediatric and pandemic response infrastructure, investing in the growth of the pediatric workforce, enhancing rapid medical countermeasure response and access to pediatric medical supplies within the strategic national stockpile, ensuring timely access to mental health care services for children as well. So these recommendations in the blueprint incorporate the results of a survey completed by over 40 CHA members and many of them members of the PPN. And as Kevin mentioned earlier, we have the privilege of working with the PPN hospitals to help move this work forward. And everything we do in pandemic and disaster preparedness space is informed by them. They've helped us develop a set of disaster principles that highlight what is needed in a national framework for disaster and pandemic response. And so moving on to another component that's also part of the PPN are the centers of excellence, which are funded by the Administration for Strategic Preparedness and Response to improve regional disaster response capability. And so the 3 pediatric centers of excellence are multi-state cooperative agreements that target the sharing of planning and response capabilities to support the needs of children during emergencies and disasters. And so in those 3 regions, you have the Gulf 7 Pediatric Disaster Network, which covers 6 states like Alabama, Florida, Georgia, Louisiana, Mississippi, and Texas, and Puerto Rico. And then you have the Western Regional Alliance for Pediatric Emergency Management, or RAPM, which covers Arizona, California, Nevada, Oregon, Washington, and Utah. And then you also have Region 5 for kids, which covers Illinois, Indiana, Minnesota, Michigan, Ohio, and Wisconsin. And so these centers of excellence are developing these coordinated pediatric care plans in their region, improving statewide medical surge capacity for pediatric care, and educating and training the healthcare workforce on preparedness and response gaps that are relating to pediatric patients. And they were a crucial component of the federal government's response to the 2022-2023 surge of respiratory illnesses by convening town halls of healthcare providers, just to give one example. So we are working with other pediatric stakeholders to ensure that funding for these COEs continue in the coming year. We're also working to advocate for the 5-year reauthorization of the Emergency Medical Services for Children program. It's the only federal program dedicated to improving emergency care for children. And through the EMSC, all states and territories receive state partnership grants to expand and improve their capacity to reduce and respond to emergencies. And EMSC funding is used to equip hospitals and ambulances with the tools to treat pediatric emergencies, to provide pediatric training to paramedics and first responders, and to improve systems that allow for just more efficient pediatric emergency care. And EMSC funding has helped to improve pediatric capacity and transport of pediatric patients, as well as address emerging issues such as emergency medical services in rural and remote areas as well. So as of right now, the full House has passed the EMSC reauthorization bill. It has not yet passed the full Senate. It did pass out of the HELP committee. So CHA has been working with partner organizations such as the American Academy of Pediatrics to emphasize the importance of this program and why it needs to be continued. And then lastly, we have, as Kevin mentioned earlier, another important component of our work is advocating for the National Advisory Council on Children in Disasters. And the council has provided advice to the HHS Secretary and ASPR on issues related to the medical and public health needs of children during disasters. And it has provided valuable reports and recommendations for healthcare preparedness for children, surge capacity, strategies for human services and child-serving institutions. And while the last council reauthorization was enacted in 2019, the COVID pandemic and change in administration had delayed some of the council committee members from being sworn in and meeting until February of 2022. So we have urged Congress to include language to ensure the continuation of the council as they negotiate this year-end spending bill, so to ensure that work continues. So I think that's all I have. So I will pass it back to Aimee.
Thanks, Natalie. And we are in the home stretch now. Just a few more slides that we'll cover very quickly so we can get to your questions and comments. You can move to the next slide. So we just wanted to cover some of our broader work as we think about more broadly in terms of the issues we're working on, but also ways in which we're kind of raising up the important role that children's hospitals play. So the first is we just wanted to highlight our work on gun violence prevention. So we have joined the Ad Council along with a lot of leading hospital and health systems on an Ad Council campaign on gun violence prevention to really raise this up. Obviously, it's the leading cause of death for children and teens, and working to kind of raise awareness of it. And efforts to address gun violence prevention. So we are signed on to that. And you can see on this slide a quote from our CEO, Matt Cook, on the effort and our involvement. You can move to the next slide. We also have Made Possible by Your Children's Hospital campaign that we launched last year that maybe you've seen on social media or other places, really just highlighting the important role that children's hospitals play in big ways and little ways in children's lives. And these are really attention getting in terms of the visuals, as you can see here. We're also working on some longer stories and examples of kids and their families that were cared for at children's hospitals, and the amazing difference that made in their lives. So we can be working on those and raising those up to policymakers to really show the role and the critical need for children's hospitals in our country. You can go to the next slide. And another really a big event that we do, and my favorite event that we do, is Family Advocacy Day. So in June every year, we bring children's hospitals and children and families that were cared for in children's hospitals to DC, and for them to meet with their members of Congress, to meet with members of the administration, to really highlight the role the hospital played, the role that Medicaid played, the role that policy has played in their lives, and really be able to kind of bring home some of our policy priorities with real stories of the difference that these policies have made in children's lives. And so we have our next one, June 11th through 13th. Hopefully for those of you from children's hospitals, your hospitals are going to be participating. It is our 20th anniversary and have a lot of fun things planned, along with all the great advocacy that the children and families do every year. So I'm gonna, now we can go to the next slide, which gets us to questions. So I know that was a lot of information. Happy to take any questions or hear any comments from the group.
That is a full agenda, Aimee and Natalie, and we appreciate your work. Let's, if you have a question, you can either type it into the chat or raise your hand using the hand function. And I've got a couple of my own just in case.
Yeah, Tom, I had one sent directly over to me, if that's okay.
Please.
All right. First of all, Aimee and Natalie, thank you so much. Very, very important information that you all just shared here. This question is coming from, I believe, a place of curiosity of what is one thing that we either in a children's hospital or outside of a children's hospital, what is one thing that we can do to help advance all of these priorities?
Well, I would say education. So I think, raising up children's issues in your states, with your federal policymakers, your federal lawmakers, really trying to raise kids up as we are, as I talked about, there's going to be a lot of new people in Congress, a lot of new people in the administration. So really reaching out to your members of Congress. If you're in a children's hospital, I'm sure you have a government relations lead you can work with to really raise up children and what children need. And I think that's step one for all of us as we look forward to early next year.
The more voices, the merrier. I think we can approach this from all different levels, as we said, and including, governor's offices and state offices as well as federal. I think that's well said. Pat Frost, everyone.
Yeah, Aimee, I have a question for you. And is there any intersection between these policies that are being advocated for Children's Hospitals Association, and what is being talked about in terms of the elimination of the Department of Education on the federal level, that would go to the states. I think there is a huge concern in the disabled community, especially with children and youth with special health care needs, and, you know, the IEPs and, you know, school nurses and all of those types of things. I'm hearing through the grapevine huge anxiety associated with that.
So thanks for that question, Pat. We have not, at the Children's Hospital Association, very much interacted with the Department of Education. We have, in terms of some workforce issues, we have, in terms of the current administration, had a lot of interest in school-based mental health services. So we did a facilitated conversation with some of our hospitals that were doing work in that area to show the partnerships. But I will say that, you know, for us, a lot of times we do, we're looking for more national framework for kids in our really health focused policy and advocacy work. And so the theme that you're talking about in terms of more flexibility or more happening at the state level, that's not necessarily always a bad thing, but sometimes we worry because we lose the kind of national framework to make sure, you know, no matter where a child lives, they can get the health care that they need. So I think we will be experiencing some of those same issues and making, you know, the case for keeping some of those national infrastructure and parameters in place. The other thing I'll say is we're also looking more at state activity. And so we actually recently hired a director of state affairs, and that's a new position for us because so much is happening at the state level. We're not going to lobby at the state level, but it's really behooves us to know what's happening at the state level, to learn what's happening at the state level, to support our federal work, but also to help our hospitals so that they have more information on what's happening in other states, opportunities and challenges, so that they can be as prepared as possible.
Just another question. Does the Children's Hospital Association, you know, with its membership and also, you know, those people who may not be members but are advocates for children, do you send out, you know, notices for, you know, legislative, you know, updates to, you know, reach out to your congressman on the state level or your senator, that type of thing, with a pre-drafted letter? I know that's a strategy used a lot in other advocacy groups, and I was just curious because I haven't seen that.
So we do for our members. So we do send out for Children's Hospital Association members. We used to have a broader grassroots advocacy network, but what happens is a lot of our hospitals have their own. So it was kind of duplicative. So I would say if you can and aren't already, connect up with your local children's hospital and get active in their grassroots network. Because they'll be doing messages like that. And oftentimes they're amplifying our federal policy priorities and have similar asks in that way.
Great. Thanks so much for those questions, Pat. Other questions? Or if you want to share experiences, insights, challenges that you faced in your advocacy work?
I have another one over here, Tom, if that's okay.
Yeah, absolutely.
Right. Aimee and Natalie, working with the previous administration and now, you know, with new President-elect Trump, are there any lessons learned from his last term that Children's Hospital Association might employ or think about doing things a little bit differently?
Well, it's a really good point. We have worked with the Trump administration before, and we actually put together a slide which I didn't include in this presentation, but there is actually a lot that we achieved during the Trump administration. I know that some people have a different view of that, but we worked on the ACE Kids Act, which was a Medicaid piece of legislation for children with medical complexity, and President Trump at the time signed that legislation and moved forward with implementation. And there were other things, provider relief funding. We worked very closely with the Trump administration to make sure that there was provider relief funding during the pandemic that made its way to children's hospitals. As you may remember, the first couple of rounds were really based on Medicare metrics, and that didn't work for us. And so we worked very closely with them, and they were open and learned a lot, I think, about children's hospitals through that process. So I think there's a lot we can take from that experience as we go into the new administration. We also may see, as we did under Biden, you know, a lot of the folks that were working under Biden were from an Obama administration. So oftentimes people will come back. So we may see people who, you know, were in HHS or CMS the last time around, or somehow involved in the Trump administration, who come back. And obviously we would have established relationships with them. But I think, as I said, you know, we always, in terms of our advisors that we contract with, we always have Democratic consultants and Republican consultants. So we have a great team of folks who can help us either reestablish relationships or establish new relationships with those coming in. And I think we will send a letter pretty early, as many other groups are doing, to the transition team. We know who the leaders are, and we've done that in the past to really highlight our issues at a high level. Probably will pursue a meeting with the transition team as well, just to make sure we're on their radar as they're coming in and thinking about the issues that they're going to focus on.
Great, thank you so much.
Thanks, Julie, for that. Other questions? This is a very interesting time to have this conversation, and I think Julie, you brought up a really good point on needing to understand. We're at a point where we don't necessarily understand the top priorities of the incoming administration, and but I'm encouraged to hear from CHA that there is an opportunity during this lame duck session to be productive, which is not always the case. But I'm really excited about you and your work, and thank you both and your colleagues for your work. I those of you that know me, I've got a newborn, and I have increased empathy for the ability for myself and my son to access the kind of medicine that you all and your members, most importantly, work for. So appreciate your work, and thank you so much for sharing policy landscape with us today. I think it's really important as we move forward into a new administration and new funding priorities, new policy priorities, I should say, that we all are paddling in the same direction, and it very much sounds like CHA at the helm is leading the charge. So again, thank you.
Thank you for having us.
Thank you.
Thank you, Natalie. Thank you, Aimee. I want to pivot now to my colleagues at Healthcare Ready, who are going to give a brief overview of our work in this space, and then we'll wrap up around 1:30. Over to you, Angie and Lily.
Thanks so much, Tom. Thank you so much, Aimee and Natalie, for that amazing overview of the policy landscape there. I never, again, want to follow on the heels of your presentations, just stating that out now, but I think that was a really helpful segue into some of the things that we'll share now. So my name is Angie. I'm the Associate Director of Research and Policy here at Healthcare Ready. My colleague Lily and I will be sharing a bit about our preliminary findings from our research so far for a project that we've been doing in partnership with PPN to really understand factors that increase pediatric supply chain vulnerabilities, or practices and policies that enhance supply chain resilience in the pediatric healthcare space. So just a bit of background on the project itself before I pass it off to Lily to share some of our initial findings. when we started outreach to partners to gather data on these kind of current policies and best practices, we naturally started by reaching out to government affairs folks on the policy side of things, thinking that we would split the research between policy and supply chain. And this may be apparent to folks on the call already, but for us, we learned very soon that the depth and breadth of people involved in implementing policy, being affected by policy in pediatric supply chain, it's everyone. And it happens at every stage of care. So when we say policy in this perspective, we mean policy that's happening at the organizational level, at the state level, at the federal level. All of the practices that are and policies that are combined to lead to ultimately national supply chain resilience. And so with that, I'll pass it off to Lily to share a bit more about the nature of the interviews that took place and some of our key findings there.
Thanks, Angie. Yes, hi, I'm Lily Scheindlin, working in research and policy here. And so a bit of background, kind of following up on what Angie was just describing around the data gathered through this project. We conducted 17 qualitative interviews that consisted of 10 open-ended questions that were aimed at understanding, like Angie just described, the current landscape of pediatric healthcare supply chain, investigating perspectives on challenges, potential opportunities, where the gaps are related to the policies that are impacting pediatric healthcare and pediatric patients, especially at all of those levels, like Angie described. And they were 1-hour interviews recorded on Zoom. And like Angie was saying, we chose to interview a cross-section of stakeholders, including those that you see listed here. So we spoke with 9 hub sites that included people from the system supply chain directors side of things, supply chain experts at the hub sites, and hub site managers. We spoke with 4 subject matter experts, including pediatric advocacy groups and organizations, public health organizations, membership organizations, and policy specialists. And we spoke with 4 supply chain specific stakeholders from places like GPOs and distributors. And on the association and supply chain side of things, it tended to be people supporting in the policy and advocacy efforts on behalf of their organizations. And we chose this cross-section, again, because we really wanted to gather perspectives on the ground from the hub sites directly in their hospitals and what that looks like, as well as from the broader environment across public health, emergency management, supply chain discussions, and get a variety of the topics and really ensure that we're fully assessing what's going on in pediatric healthcare supply chain. And so that leads me to discuss just some of our preliminary findings here. There's a lot of data that we're still sorting through, but just to set the scene a bit, as Natalie and Aimee discussed, something that came up a lot in the interviews, I would say in many or most of them, were that pediatrics is an overlooked population, and kids don't vote, they don't pay taxes, their needs can be more easily, if unintentionally, overshadowed. And so as pediatrics are a smaller volume of patients with those uniquely specific needs, it can be riskier for manufacturers to take on production of pediatric products, medications, leading to less redundancy and less robustness throughout the supply chain. And so, as we all know, that the healthcare supply chain is already complex, the pediatric healthcare supply chain is just, that much more fragile. And so one of the things that came up the most from the interviews in being really important to building and maintaining supply chain resiliency is coordination and collaboration. You can see from this word cloud here that is visualizing how the themes, or which of the themes, cropped up and how much or how frequently throughout the interviews. Coordination and collaboration came up 18.21% at the time. It was the most discussed topic around across interview responses, which underscores the significance of communication and that collaboration across healthcare teams and supply chain entities, both internally and externally in efforts to bolster supply chain resilience and preparedness. And this came up at all levels of supply chain interactions. So one thing that was talked about a lot was how recall and communication around product recalls is disseminated throughout a specific organization, a hospital. There's sometimes some gaps in that information transparency and how that gets disseminated. So we heard from organizations how using different tools like Workday within their organization is helpful. We heard that using and relying on regional and local networks can be really helpful. And we also heard about how communication at the federal level is really critical. And there were several sub-themes that came up, for example, within coordination and collaboration. So participants described how relationships and relationship building was really important in ensuring that they get access to all of the products and medications that they need to support pediatric healthcare. The pandemic was referenced, infant formula shortages were referenced, and again, we're seeing it with this current IV solution shortage. And a few other sub-themes came up, including, again, how communication within internal organizations was really important, but communication between the organizations and external parties is really key, and making sure that information is being delivered easily and transparently across every area of the supply chain. And so essentially some of these findings are, suggesting that policies might, it would behoove us and the pediatric populations to have policies that incentivize and prioritize that coordination and collaboration at all levels. And I'll pass it back to Angie to discuss it a bit more.
Thanks so much, Lily, for the excellent overview on the findings for coordination and collaboration. As Lily mentioned, 20% of our time in interviews was spent strictly talking about all these topics related to how we can be coordinating better, how we can be collaborating better internally to our teams, between the clinical teams and the supply chain teams of a health system, as well as across coalitions, across regions, and so forth. There were some other topics that arose significantly as well, not nearly as significantly as coordination and collaboration, but the four other topics were supplies and products, that specifically problems that are related to specific supplies or products, quality issues, availability, and adaptability, and so forth. About 10% of our time was spent talking about pediatric specific supply chain issues. So that's what we're referring to, kind of systemic challenges leading to pediatric supply chain resilience challenges, over-reliance on single source suppliers, fewer manufacturers in the space, for instance, those kinds of systemic issues that persist. And then other topics that cropped up frequently: supply chain disruptions, the nature and causes of supply chain disruptions and how that impacts our patients specifically, and the rest on general supply chain operations things. And so from these interviews, there were so many different topics that came up where we wanted to focus our time and attention to, as we started to tease out what we could address in this research, was what are some of the emerging themes that we can relate to translate into practical solutions? And so I want to move us into the next slide here. One of the questions that we asked all the interviewees from the private sector and across the PPN hub sites was, what policies come to mind when you're thinking about pediatric supply chain resiliency? Clearly, we asked the question to Aimee, and then Aimee and Natalie, and those are all the policies that came up in the presentation. But, a lot of times this is a really hard question for people to answer. There are no specific policies necessarily that really came to mind frequently or consistently across the groups that we asked this question to. And you can see the list of some of the policies that did come up, some that we touched on earlier in the presentation today too. I will say that, when asked what are the key policies that we would want to advocate for or support for as we think about the next couple of years ahead, one of the key areas that came up a lot from many different interviewees was this topic of nearshoring or onshoring strategies to reduce reliance on global supply chains. More on that to come in our final report there, but I will say that I think the point that we are wanting to emphasize through these conversations that we've had so far in these interviews is that as we talk about national supply chain resiliency, like including decisions on international trade policy and global sourcing strategy, what can we in all of our positions be doing to make sure that pediatrics are not overlooked and that their sensitive supply chains are really elevated throughout all of these discussions? And so moving on to the next slide, and I want to ask everyone here on the call today, what are some of the practices and policies that have been important in your organization or that you've seen are really impactful in advancing supply chain resiliency for pediatrics that are necessary for us to be amplifying throughout the field? So feel free to drop in the chat if there are any practices or policies that you've seen are really, really important within your organization or across the field in general. Where we're thinking about is across this really diverse landscape of stakeholders that can have an impact on supply chain resiliency. What are some of the guiding questions that we can share that we can all be looking to make sure that policymakers, as they're making decisions, are integrating pediatric considerations into their assessments? So, for instance, if they're asking, how does this regulation support access to critical supplies for overlooked or special populations? We already know that the numbers don't pan out for pediatrics. We can't rely on using numbers to make this argument that, how do we include pediatrics? We need to make sure that they're asking this question specifically and assessing a policy from this perspective. Another thing for policymakers to be asking themselves, or for us to be asking decision makers, is how does this policy address volume fragility or specialized nature of pediatric supplies? They should be asking themselves, are pediatric specific products and needs explicitly considered in the policy? We mentioned DSCSA. There's a lot of discussion around there. It's been in progress for 10 years. There's a lot of there's no special provisions that have been made for pediatrics there though, as with many other supply chain specific policies. So I think some of the key things to remember here too, as we're kind of move forward in the conversation about what we're going to be doing this next policy, political landscape, how can we, in all of our roles, be highlighting and emphasizing and making sure that decision makers are asking themselves these questions at every stage within our organizations, across the coalitions and networks that we're involved in, and at the federal level too. I see a couple of points made here in the chat. Gail, thanks for bringing up public health and emergency disaster preparedness policies and laws. Absolutely. There's a lot of general public health preparedness and disaster policies that are kind of on the table that'll be rediscussed in the next administration, the reauthorization of PAPA, for instance. Depending on how those policy discussions go, what are our advocates doing to make sure that there will be sufficient funding and support for pediatrics healthcare supply chains, and not only just the healthcare supply chains, but also our workforce there? Is there sufficient funding and investments being made to make sure that we're not only building up the processes and mechanisms for managing shortages, but also enhancing and strengthening staff skills to be able to adapt to disasters? Kevin, in his role as HPP director previously, coordination is so important. And also you need resources to be able to enable that coordination to happen, that relationship building. Absolutely. There are several more comments here. Julie, do we have time to go through each of them, or are there?
We do not. But I'll go through them really quickly right now. So I think the healthcare coalitions is a really good tool, especially for non-hospital pediatric entities to get involved into a larger ecosystem for themselves. And just going through, Michael, be transparent on the big picture of how follow the money, how to get corporate supply chain entities to the table when there are charities and NGOs there as well. Conflict of interest of who is volunteering and donating, who's getting paid. Yeah, potentially. And I think that's an interesting point. Who's a client versus who is a partner. I think understanding where people are coming from is important, especially as we pursue, again, a unified approach to ensure pediatric supply chain is as strong as it could be. Pat Frost says more shared awareness across coalitions, 100%. I think that transparency and that sharing of best practices is really important. I think this venue and the venue that is provided by the Centers of Excellence and PPN is a really good way to amplify some of these best practices across coalitions, but also across any kind of partner that serves a pediatric population. Kevin says, for response, a state-based advocacy team that can provide recommendations for use of scarce resources, COVID experience with a variety of specific resource shortages. Absolutely. I think that there is a lack of centralized advice for that, especially at the state level, that kind of forces individual hospitals and individual healthcare entities to chart their own path forward when there is shortage or the imminent threat of shortages, as we saw during the IV solution. And Kevin PPN posted something to that effect. We've got a couple other one. Advocacy is one thing, procurement is another. Yes, I think that's correct, and a really interesting I think approach to this, which is we have procurement challenges now, and one of the problems I think is that there are so many players in this space, and there is a lack of alignment in terms of making sure that we're seeing a bigger picture here. I've got to wrap this up. We are at 1:30, but I hope that this was really engaging. Certainly this is a fascinating conversation with our CHA folks at this really critical time, as I've said before. And I think our key takeaways here are again, we're all aligned on the intention here, and I think developing some concrete objectives and concrete pieces of policy or legislation, but also just advocacy frameworks in which we can approach conversations with our policy makers is absolutely critical. Just as critical for that, we heard it from CHA for developing relationships with policymakers, but also across the supply chain and across our peer organizations. Those relationships are absolutely critical to ensuring that we're having good collaboration, coordination, and communication to ensure that the frameworks that do exist and what we have that exists today is being optimized to its furthest extent. I do want to just, Kevin, any last words from you, sir? And we'll close out.
No, just thanks that we're all walking this path together, and the way that we can leverage the strengths of these unique organizations certainly gives me hope that we're headed in the right direction. Thank you so much.
Thank you, Kevin. Thank you to PPN. and to CHA and to all of you who ask questions. I really appreciate you all. And there will be more of these sessions to come, and these slides will be sent out with the additional offerings from PPN and Healthcare Ready. Thank you all so much. Have a good week.